Hello and good afternoon. Welcome to the Grand Rounds presentation for today, which is entitled The Crisis in Human Service Delivery, Chronic Organizational Stress, and Ideas about What to Do About It. A few housekeeping items before we begin and before I introduce our speaker for today. Your mics and cameras are off except for presenters and interpreters. We do welcome, though, your feedback and questions using the Q&A function. And I will actually be monitoring that Q&A box for questions to be able to share with the speaker during the Q&A portion at the end of the hour. There are a few ways, as always, to provide your feedback and receive continuing education credit using our evaluation form. We'll post a link to that form in the chat prior to the end of the talk. That link will be available at the end of the presentation, and if you have not had a chance to do it, an email will be sent out with the link on the next day or so after the presentation. And without further ado, it's my distinct pleasure to introduce our speaker for today, Dr. Sandra Bloom. She's a board-certified psychiatrist, a graduate of Temple University School of Medicine, and currently Associate Professor of Health Management and Policy at the Dornsife School of Public Health at Drexel. She's also the founder of Creating Presence, an online organizational approach for creating trauma-informed systems. In her work, her mission focuses on making service delivery trauma-informed and trauma-responsive, with an eye toward also making this affordable for systems. From 1980 to 2001, Dr. Bloom served as founder and executive director of the Sanctuary Programs, inpatient psychiatric programs for the treatment of trauma-related emotional disorders. She's recognized nationally and internationally as the founder of that model, around which hundreds of social service, juvenile justice, and mental health organizations have been trained. She's a past president of the International Society for Traumatic Stress Studies and co-author or author of a series of books on trauma-informed care and trauma-informed systems. Her efforts focus on advocacy for public policies and programs at the federal, state, local, and tribal levels that incorporate up-to-date scientific findings regarding the relationship between trauma across the lifespan and many social and health problems. And with that, I'm delighted to hand it off to Dr. Bloom. Thank you so much for joining us.
Thank you, Zipporah. It's a pleasure to be with all of you today. The first question is there a crisis? And I think probably this audience, you will agree that there is a workforce crisis. This is from Alan Francis, who many of you probably know of his work. He was the head of the DSM-4 task force. And he is quoted quite recently as saying, the past 50 years of neglect and criminalization have made the US one of the worst places in the world to have a mental illness. And this was from a New York Times Magazine article about the CDC, but I think it really applies to all of our systems, that you can't starve and neglect something over and over for decades and then expect it to function perfectly in a crisis. And we are certainly in a crisis. I want you to know that my knowledge about this, as Zipporah indicated, it comes out of starting and running an inpatient unit from 1985 to 2001, and also having a large private practice. And during that time, even though we were doing this really critical founding work around how to treat adults who have very complex psychiatric problems, we had to move our program 5 times. And it was never because we weren't making money for the hospital, and it wasn't because we were failing. It really was because of these much larger changes that began happening, well over 50 years ago, really. So that's the point I want to make, is put this into a larger context rather than focusing on individuals. And that's where most of the work on burnout has been, on looking at how do we prevent that in individuals. It's been noted that professional burnout is an epidemic in America. Research shows that between 35 and 54% of US nurses and physicians have substantial symptoms of burnout. And this is particularly distressing. 45 to 60% for medical students and residents. So this can't be because of patient contact. Medical students haven't had that much yet. It's got to be some larger issues that are going on that are really interfering with people's capacity. And then if we look at the mental health, I'm sorry, is this band in the middle of what you guys are seeing? For some reason it won't, no, you're okay? You don't see it, okay. So studies estimate, and this is really interesting, between 21% and 67% of mental health professionals. That's a pretty wide span.
Dr. Bloom, I think you might have muted yourself.
Okay, sorry. I can't get this thing off of my screen. Okay, so what that means is that if 3/4 of mental health practitioners are experiencing signs of burnout, this can't just be an individual problem. And of course, I don't believe that it is. Ironically, when you look at the research, the mental health field has paid relatively little attention to the health and well-being of its own workers. Relatively few well-designed empirical studies have examined burnout in mental health, and particularly in mental health organizations. And all of this is before the pandemic. And what we know as a result of the pandemic is that people in every sector are having a great deal of difficulty. And then there's the issue of workplace violence. This is from our local paper. There was a nursing assistant on a, not a mental health floor, regular medical floor, who was gunned down by a coworker. And it was horrible. Nobody knows exactly why, but it's an example of the enormity of exposure to violence in healthcare, and certainly in mental health care. So much in mental health care that we often don't even register it as violence or report it or do anything about it, really, because it's so common. And then mental health care, as you all know, was severely inequitable before the pandemic. And the pandemic certainly has not helped. So that's kind of where we're at. What I want to look at is what's been defined as the central act of caregiving. And I think this is a beautiful definition: to repair to the extent possible the wounded humanity and state of inequality and vulnerability of the sick or injured person. So that is what we are all supposed to be doing in healthcare, in mental health care, and all the related social services. That's why people go into the work, is because it's going to give them meaning and purpose to their lives. They don't go in it to make a fortune, obviously. Arthur Kleinman at Harvard has pointed out that the great failure of contemporary medicine to promote caregiving as an existential practice and moral vision that resist reduction to the market model or the clarion call of efficiency has diminished professionals, patients, and family caregivers alike. I think what people who go into healthcare, so this helps to explain, I think, why medical students would immediately be experiencing at such high rates burnout, is because in our country, and often in extension, all of Western society, profitability trumps all other values, including often the value of life itself. Well, that puts practitioners into terrible situations, moral dilemmas and situations of moral distress. Moral dilemmas are situations where we don't know what the right thing to do is. Moral distress is experienced when we think we do know what the right thing to do is, but we're constrained from doing it. And it's something that I found in delivering mental health services that we just didn't, on a large scale, talk about it. We did not talk about all of the changes that were happening that would definitely affect healthcare back 30, 40 years ago. We didn't really have the conversations that we needed to be having. And so these issues of moral dilemma and moral distress are almost implicitly now part of our systems that we rarely really address. We just have adapted. Well, that causes over time moral injury. Jonathan Shea has talked about this after working with Vietnam vets his whole life. And its definition is that it's present when there's been a betrayal of what's right, either by somebody in legitimate authority or by oneself in a situation that's high stakes. And pretty much we don't deal with any situations that are not high stakes in somebody's life. Silver has described it as a deep soul wound that pierces a person's identity, sense of morality, and relationship to society. And I really believe that it's this level of systemic problem that is so fundamental to the experience of burnout. But it exists as a deep soul wound, not necessarily as language that people can really think about or have discussions about. But all of this has a ripple effect on all of human services, all of which are meant to be connected and integrated with each other. And of course, that is a huge problem. So when you put people together, if actually 2/3 of mental health workers are experiencing burnout, that means that the rate of burnout in our organizations is extraordinarily high, if that's accurate. So what might that do? What might that look like at a collective level? Well, we have to challenge some assumptions to even talk about this. And the basic assumption is that the older paradigm that has dominated our group life and our individual existence for several hundred years sees our bodies, that's why we still have a mind-body dichotomy and why we still struggle to have parity, sees our bodies as machines and similarly sees our organizations as machines. So you get a lot of mechanistic language in organizational systems about how they're supposed to work, and if you're in a leadership position, how you're supposed to make it work. Just that it's not a very good paradigm. It doesn't work because all of our organizations are really living systems. Everybody within them is a living system. And these folks, this is from a book from the business world, make the point that when they're not using it as a metaphor, nor am I, for how human institutions operate, it's real. It's the way they really are. And the concepts about organizations as alive is really derived from a whole lot of different theory, ideas, and knowledge that has been coming into the world in the last few decades, really, to look at, wow, how do living systems, how are they different from systems if we look at systems as machines? What's the difference? Well, when it comes to trauma theory, what the epidemiology of childhood adversity and lifetime trauma exposure shows us clearly is that we live in an interconnected, complex, adaptive, living world that is literally filled with people who have had adverse individual, group, and intergenerational exposure to trauma and to adversity in all of its different forms. So that is not just about our patients, but it is about our patients, but it's also about all of us. It's not like, we go through life carefree as a mental health worker. That's not real. It's not like all of us had ideal childhoods. So really, it's the interactions that are really complex between traumatized clients, stressed staff, pressured organizations, and the current social, political, and economic environment that we are all immersed in. That is an issue of great complexity. And we mirror our organizations, and our organizations mirror us. And we call that parallel process. This is from a definition by a social worker at the University of Pennsylvania, Kenwin Smith, in an article where he was consulting with outside of the mental health system. It was in some industrial setting. He noticed that his team of consultants were running in parallel with the very problems that they were there to consult about. And he called it parallel process. When two or more systems have significant relationships with one another, they tend to develop similar thoughts, feelings, and behaviors. So many of you, hopefully most of you, will know a lot about how trauma and adversity affect the patients that you're working with. Now I want you to kick that up a notch and think about that same knowledge as applied to the places where you work and the people that you work with. That's what I mean by parallel process. Our systems as a whole are under significant stress. This does not come as a surprise to anybody. All of the issues of racism and sexism and heterosexism and ageism, and you name it, the profound social splitting that is more now than I have ever seen it, the background of historical trauma and the effects of the pandemic and long-term problems with communication and poverty and corruption. And of course, in the background, always this huge issue, impending, terrorizing issue of climate change. Well, if organizations are alive, then like individuals, they are living, complex, adaptive systems, and being alive, they're vulnerable to stress and all that goes along with stress, particularly chronic and repetitive stress. And I'm going to make the case that that's really what I'm talking about. And then organizations like individuals, therefore, can be traumatized, and the result of traumatic experience can be as devastating for organizations as it is for individuals. When we join a group as an individual, because we are a group species, that group becomes a part of our identity, our individual identity. So there is this constant interaction with our own personal identity and the identity and experience of all of the people around us and the organization as a whole. So what kinds of things cause organizational trauma? Well, I'm sure you all know: suicides, homicides, other patient or staff deaths, lawsuits, losses of funding, patient or staff injuries, episodes of sexual abuse, media attacks, other traumatic events, losses of key staff, losses of key leaders, losses of whole programs. All of these, from an organizational viewpoint, can be considered traumatic to the organization as a whole. I can't see all of you, but if I could have everybody raise their hands, what I would see is it probably, and I asked the question, how many of you have ever worked in a traumatized organization? Most people would raise their hands. That's what I experience when I talk about this to large audiences. It's kind of astonishing, actually, when you ask the question and you see that, wow, everybody has. Well, what happens under those circumstances in the big context? I think the system becomes trauma organized. That's what happens to our patients. Their lives become organized around their previous really bad experiences. So I've defined it as when a system, whether we're talking about a person, a family, an organization, a community, or a whole society, becomes fundamentally and unconsciously, underscore unconsciously, organized around the impact of chronic and toxic stress, even when this undermines the essential mission of the system. What's that look like? Well, think about chronic hyperarousal in your patients. This is organizational hyperarousal. And it's when everything is a crisis. never get any time to talk, never get any time to really confer. It's just this rapid thing going on all the time, and everything is immediately not at a level of 3, but at a level of 10, no matter what the problem is. That's organizational hyperarousal. When that happens, there will be a widespread loss of basic safety and trust. Nobody has to do anything bad for that to happen. That's what your patients feel when they are chronically hyperaroused. That's what all of us feels when we are in a chronically hyperaroused organization. We don't feel safe, and we don't know who to trust. And that's disastrous, because as this man pointed out, it's almost impossible to successfully implement high performance or high commitment work practices in the absence of mutual trust and respect. So no wonder things continue to go haywire. What does that look like? Well, it looks like people can control their emotions, but everybody does it individually differently. So some people look like the guy on your left, other people look like the guy at the top, and other people will just be losing control and screaming at other people and being really disrespectful and doing all kinds of things. All of that is a symptomatic of a widespread loss of emotional management. And then there's communication. Organizations are built, maintained, and activated through the medium of communication. If that communication is misunderstood, the existence of the organization itself becomes more tenuous. Well, what happens to communication under stress? Because this has been well studied. Perceptions narrow. The context, which is much more complex, of the information is lost. Communication increases top down, but it decreases bottom up. So it doesn't take long before people in leadership and management don't really have a clue what's going on down at the ground level. And it's a problem around the communication network. Feedback loops under stress break. Now remember, talking about a living system. If the feedback loops in your body break, you can die. In a system, when people, individuals or whole groups of people are not communicating with each other because their feedback loops don't exist, then the organization is becoming progressively ill and dysfunctional. Complex team behaviors decrease, and that means that the risk for more dangerous things to happen increases. How will you know? What are the signs of that? Well, 70% of your organizational communication comes through the grapevine. Happens much more rapidly than any kind of formal system. But the grapevine can be poisoned under the influence of chronic hyperarousal. So you will hear increasingly bizarre rumors that are not attached to any facts. And we will never stop gossiping. It's part of our species. People have made an analogy that gossip in human beings is analogous to the way monkeys pick bugs off of each other's hair. But what you'll see when the grapevine is getting poisoned is malignant gossip increasing. People saying really terrible things about each other. And what you will also note is that there are more elephants in the room, what the business world calls the undiscussables. We call the elephants in the room. It's the things that people talk about only at the meetings after the meetings, or the meetings after the meetings after the meetings, but they never really bring it up any place where anything can be done about the issues and the feelings attached to the issues. So what kinds of things become undiscussable? Questionable business practices, financial inequities, criminal behavior, suicides, homicides, episodes of sexual abuse, any kind of sexual misconduct or harassment, any kind of shameful act that can include episodes of racism, sexism, homophobia, transphobia, ageism, ableism, you name it. All of this will become, people will talk about it, but not necessarily bring it up anywhere that anything or any conflicts can be resolved. And so it just goes further underground, but it doesn't ever go away. That's the thing about elephants in the room. They take up a lot of space. Under these circumstances, we are likely to engage in more interpersonal conflict with each other. And the real fundamental problem with that is that there's an inverse relationship between interpersonal conflict and task conflict, meaning if there's a lot of interpersonal conflict, we won't have the kinds of discussions and debates that we need to have to really do good treatment. We won't have them. We won't engage in them. People will just step away and shut up and not say anything, even though they profoundly disagree. In this way, we get more silos. We become very siloed. And I've called that a manifestation of organizational dissociation. That basically the organization is this massively dissociated being with broken feedback loops everywhere. When this occurs, we're more likely to lose information. We lose organizational memory. And in fact, in the mental health system, entire discourses get thrown out for no obvious reason and then are not taught to a younger generation. It's really amazing how consistently that's happened in the mental health system. That means then that we don't learn from the past, and there's an oversimplification of what is actually very complex. And I don't mean to offend anybody, but we changed around 1980 from calling ourselves mental health to calling ourselves behavioral health, as if the only thing that really matters is behavior. But what we've learned from trauma is that behavior is the outcome. It's not causal. And so we've ended up, I think, in many, many boxes unintentionally. And then we fail to unlearn strategies that actually don't work. So we keep doing things that don't work. What happens to decision-making under stress? Attention narrows. There's more and more of a focus on threat. We get cognitively rigid, and that means it results in premature closure, that we haven't generated all the possible alternatives and possible consequences, which of course is more likely to happen if we don't trust each other and we're in conflict with each other. So as decision-making becomes increasingly non-participatory in any meaningful way, then problem solving becomes more reactive. And that means we get more and more short-sighted policy decisions that actually make things worse. They don't actually make them better. And I call all of this really a manifestations of organizational learning disabilities, that what should be a learning organization actually develops learning disabilities. We have difficulties with learning under stress. We fail to integrate important information. The people that leave take their knowledge, their tacit knowledge, all the knowledge based on experience out the door. And often we don't tell the truth about explicit knowledge. We label things, and that restricts new formulation. Think of our diagnostic system. We put people into diagnostic boxes, and that often creates self-fulfilling prophecies. And then systematically for decades, we've been filtering out all this information about trauma, which really isn't new. And then we see this deterioration of memory and an inability, therefore, to address complexity. And all of that leads to mindless, highly unscientific organizational reenactment, where we keep repeating a past that doesn't really work. What will happen under these circumstances is your best people will quit and try to find a new job, and everybody else just learns to shut up and not see and not hear. They don't step up to the plate. They're not really actively participating, and they've learned to be helpless. So there'll be widespread learned helplessness. As the situation feels increasingly out of control, people in a leadership position often feel compelled to become more controlling, more punitive, because they're trying to forestall what feels like impending chaos. But the way staff respond often to those perceived punitive measures is by acting out passive-aggressive behaviors, and becoming more distant and less participatory. This may give rise to authoritarian leaders who are incredibly dangerous. Why? Because they have cognitive problems. It's been well studied. People who are high in authoritarianism don't think particularly well and cannot deal with complex problems. And we don't see any problems that aren't complex problems. So that's a huge problem. But it's how you easily become a hostile workplace. Dissent gets silenced. There's more and more secrecy, more and more aggression and bullying, which then becomes normative. And people then become loyal to authoritarians and fail to protect everybody else. It's well established that silencing dissent means that your group is going to do poorly. That's why it's so dangerous. And it's how we're likely to emerge toxic leaders or even petty tyrants. When dissent is silenced, secrecy increases, fear increases. It becomes a fear-based environment. And that's really a toxic formula for leadership. And it's also the time where predators find the organization vulnerable and are likely to enter because the organization has become really unable to protect itself, because that kind of protection requires everybody to be involved. People who then are in the system for any length of time experience grief, organizational grief. And similarly, losses to the organization are not just experienced collectively, they're also experienced by each of us individually. I don't think it's a coincidence that the ideas of zombies has become such a cultural meme. I think what it represents is an unconscious recognition that there's been a profound loss of complex thinking skills, and that we at times may feel that we are functioning like zombies. So I would change the word burnout or add to the word burnout a sense of profound demoralization, because I think that's what happens to us. And I know it's what has happened to me in the past. And sometimes systems collapse. The society often keeps us going even when we're highly dysfunctional because they need us, but systems can and do collapse. The hallmark of trauma is fragmentation, and we have profoundly fragmented systems of care. So, how might trauma-informed knowledge make a difference in all this? Where do you even start? Well, the science of trauma and adversity indicates really a fundamental change, excuse me, in causality, which leads to a change in worldview. And it's not, again, our predecessors have been talking about this. This is from George Albee, who was a psychologist who focused on prevention. And he said, to argue that there are a number of separate and discrete mental illnesses, each with a separate but undiscovered cause, obscures or blocks consideration of the possibility that most emotional disturbances are a result of dehumanization, powerlessness, and victimization by social cruelty. And that is, in fact, what we now know as a result of the study of trauma and adversity. And we're learning more and more every day. It's about fundamental causality. And caregiving turns on the amelioration of suffering. The way I think about it is this: the study of trauma and adversity is the science of suffering. That's really what it's all about. I contend that exposure to systematic adversity and trauma is really a central organizing principle of human thought, feeling, belief, and behavior that has been largely, if not completely, overlooked in what serves as our explanation of and responses to human behavior. the way we came to understand that as a team when we were looking in 1991 at how we had changed, because we had come to understand that we had a whole psychiatric unit filled with people with complex PTSD, though we didn't have that term yet. And my friend Joe Fotorero, who's a social worker, he said, well, you know, it's really, we've changed the fundamental question. We no longer ask people what's wrong with them. Now we ask them what happened to them. And that has changed everything. And that's become kind of a national kind of slogan for what this all means. It's kind of like if you are born with blurry vision and nobody tells you that there are anything called glasses. And then somebody, hopefully your parents, decide you need to see an eye doctor and you put on lenses for the first time and the world changes. Everything becomes clearer. And that's what the issue of trauma and adversity about. It's really about this deep underlying change. You put on different glasses. It doesn't mean everything else is irrelevant. It just means that you change your perception pretty entirely. I think what we have access to is a unified theory of disease in living systems. Hans Selye pointed out that every stress leaves an indelible scar, and that the organism really pays for its survival by becoming a little older. And that's really what we've learned. So if you think about this notion of parallel process and what we know about healing and recovery in individuals, and we've learned a lot, doesn't that offer ideas to organizations? So let's just summarize the hallmarks of trauma: a lack of safety, amnesia for a distortion of the past, dissociation, problematic emotional management, experience with abusive forms of power, and therefore disempowerment or abuse of power, problematic relationships, unresolved conflicts, unresolved loss, and then adapting as best one can to all of this. And the adaptations are often quite problematic, and being unable to imagine anything else. Healing and recovery then means we have to establish safety, recover memory, integrate knowledge, provide emotional management strategies, empower people, promote the development of relationships and trust, have conflict management resources available, allow for grieving over loss, and focus on growth, learning, change, and envisioning a better future that we want to get to. How do you encapsulate all this? Well, I want to introduce you to Walter Buchanan. Some of you may have heard of. He was at Harvard and the head of physiology back in the 40s. And he said the social organism, like the bodily organism, cannot be vigorous and efficient unless its elements are assured minimal conditions for healthy life and activity. And he's the guy that gave us the fight-flight response. So he knew whereof he was talking. In 1940, he became the president of the American Association for the Advancement of Science. And in his address in New York City, he said, the most efficient and stable human society would be a body politic modeled after the organization of the human body, a biocracy, in which the myriad of differentiated cells would be organized into functional organs, all cooperating in a dynamic democracy in which any form of dictatorship would lead to degeneration and death, because that's basically what cancer is. Well, I love that term. So let's just brainstorm a minute about what a healthy biocratic organization looks like. First of all, it doesn't happen overnight, no more than your body grows overnight. So friends of mine who do a lot of trauma training say 2 to 4 hours of training, people can become trauma aware, 12 to 15 hours, trauma informed, 40 to 50 hours, trauma sensitive. To be really competent takes more than 120 hours. And for a whole organization to embrace this change, it takes at least 18 months. I've called that becoming trauma responsive. If you are in a leadership position, it means you're going to have to find some way to find time to reorganize your group's DNA, basically. And that means really focusing and having time to focus on what do we really believe? What are our values? What's our mission? Because the mission has to be driven by a coherent practice, shared value system that are that's modeled by leaders and that can be seen in routine daily behavior. You just walk on into the program, on the unit, wherever you are, and you can actually see those values being modeled. In Presence, this new thing I've created, we use 16. We use the acronym Presence: partnership and power, reverence and restoration, emotional wisdom and empathy, safety and social responsibility, embodiment and enactment, nature and nurture, culture and complexity, emergence and evolution, as the framework for our value system. Now, leaders are the brain of the organization. And the job of leaders, like that of your own brain, is coordination, central regulation, and integration of all of the different functions that it takes to keep an organization alive. And leaders have to provide the vision and the moral purpose and make sure that everybody is morally aligned with that vision and moral purpose. That does not happen overnight. That's a process. It means the organization has to review its history, the founding vision, the history of trauma, the history of loss, the things that have failed and the things that have worked, while recognizing that to the extent there's been trauma and loss, the organization has adapted to those, but the adaptations may have become really dysfunctional. And you can't know that because it gets normalized. So you have to spend the time to really review the history and the outcomes of that history. A biocratic organization develops a shared language for working together. And we used SELF. This emerged out of our work with our patients, and it stands for safety, emotions, loss, and future. It's simple enough for anybody to understand. It really conveys indispensable ideas about healing from trauma and adversity without having to focus just all about trauma. It becomes an effective problem organizing and problem solving tool, and it gets everybody on the same page. It's dynamic because you use it like a compass, and it's applicable to kids, family, staff, organization. It doesn't matter. Anybody, it's human. It's about human words. A biocratic organization has well-regulated emotions and is emotionally intelligent and understands individual and group dynamics. What's that mean? Well, it means that you have to recognize emotional dysregulation as a primary sign of exposure to stress. And therefore, you have to have tools in place that help promote emotional regulation for everybody so that emotions are honored, but they don't run the show. And there's a recognition that emotions are extremely contagious and very rapidly become collective. A biocratic organization recognizes that exposure to trauma and adversity is fundamentally about the abuse of power. So it encourages participatory democratic structures. It minimizes and confronts the abusive use of power wherever it happens, and values diversity in every form because that's the only way we get to, not just because it's right, although it is, but because it's the only way we can get to finding complex solutions to complex problems. We have to get many different points of view in the room and then figure out how we're going to integrate all of it. A biocratic organization, like a body, has circulation. Circulation is how the body communicates within itself. And it's how it brings energy to different parts and removes toxins. But it's all based on feedback loops. And there are many, many barriers to human communication in an organization. They can take any form. So you have to ask, who's not talking to who? And where are the blockages? A biocratic organization has a healthy digestive system. What's that? Well, what's the food for an organization? It's funding. So it has to turn that funding into energy that allows you to do the work. So key questions for every program. What should we hold on to as we learn more and more? What should we get rid of, eliminate, and have to unlearn? And what do we need to learn that we just don't know enough about yet? A biocratic organization is able to self-protect. It develops what I've called social immunity, the social body's ability to recognize and respond to threats, excuse me, to its well-being. How does it do that? Well, you got to protect the perimeter. That means the community has a clear, practical value system that is in constant use. New members have to be carefully oriented and adequately trained. The group has to identify the values, norms, and rules to be established and makes that familiar to everybody. The culture has to be really explicit, consciously and deliberately planned to promote the group objectives, and it has to be continually monitored, either formally or indirectly. And evidence of any weakening of the culture, just like in your body, has to provoke an immediate coordinated response by the entire group. When you are in danger of being infected, your entire body responds to that. That's what has to happen in an organizational body. How do we know? Conflict. Conflict is the alarm bell of the social immune system. So you have to have wide definitions of what constitutes violence that are universally understood and addressed, because the establishment of safety is the starting point for all learning and healing. And the best protection against violence is a shared commitment to nonviolence. But that means you have to have a rapid and proportionate response to any kind of violation, not just the violation of physical space, but also psychological space, social space, moral space, and cultural space. But that means you have to have routine employment of conflict management strategies. And you have to use all kinds of conflict as opportunities for new learning. And you have to seek integrative solutions all the time that challenges the present problem solutions that we're using. And a biocratic organization heals after being hurt. But it's important to remember, if the initial injuries occurred a long time ago, the organization has adapted to what may in fact end up being a crippling situation. So too much life energy is going into suppressing the pain and not enough to promoting growth. And that requires a whole body mobilization of how are we doing? And it's always important to remember that laughter is the best medicine. So a biocratic organization knows how to party and celebrates every chance it gets. A biocratic system has to share a knowledge base. So some questions for you to take back to your organization, and Zipporah will have this handout for you, is what do we already know about health and well-being? Not just about illness, but we should be pointing towards health and well-being. What do we already know? What do we already know about trauma and adversity? What do we already know about development of the brain, of body, of beliefs? And let me urge you to do a study group on Bruce Perry and Oprah Winfrey's new book, which is, it's just wonderful in terms of getting across really complex things that many of us didn't learn in our programs about development of brain, body, and beliefs. Do we have internal expertise that can be further shared? What other resources might we access? How can we share this knowledge with our entire staff? How will we educate all our stakeholders, our patients or students or clients and family, whoever your stakeholders are, including your boards of directors, if you have those. Look at your own organizational body. Think of it as you think of your own body. What does it look like? What do you notice about it? What's its temperature? What are the emotions that you can pick up? How well is the immune system functioning? Now, look at the boundaries. What violence is occurring? Are you charting it? Are you recognizing it, or do you just take it for granted? What is its level of fitness? What's its health and well-being? Is any attention paid to that? Not just for the clients, but also for your staff. And does it get good food? How's the funding? Does it exercise? Does it change and grow and is stimulated to be a learning organization? Now, if we think about that a little deeper, the how of attending to health, really simple. You can begin with what are the safety issues, again, broadly defined. What are the emotional management issues? What are the loss issues? And what are the future issues? Why change? And then the what of attending to health. So if we look, we use presence, it's just some questions I came up for. Where and when is power being abused in our system? Where and when is effective power not being implemented? How can we turn a power-based relationship into more of a partnership? Where and when do we discuss meaning, person, purpose, commitment, ethics, moral injury? Where and when do we demonstrate respect for each other and for our patients? Where and when do we demonstrate disrespect? Do we carve out time for a deeper understanding of each other and our patients? What conflict management resources do we have available and do we use? Does everyone have a deep enough understanding of how the person's problems arose so that empathy is not blocked? Do we define safety as only physical safety? And if so, how might this be a problem? Do we expect everyone in the community we work with to behave in a socially responsible way, including our patients? If so, do we talk about it, define it, and hold everybody accountable? Does everyone understand that symptoms are the nonverbal cries for help? How do we typically respond to these cries for help that pose the biggest problems for us? How do we get into reenactments with each other and with our patients that keep us stuck in time? How much do we actually understand the complexity of human development and use that to assess and understand everyone we deal with? How embedded are we in a medical mechanistic model that gets in the way of understanding each other? What's the quality and nature of our organizational culture? How do we know if we're becoming ill? Do we have methods to teach, learn, and integrate the complexity of the current challenges in our culture with our patients? And what would we like to see emerge as a result of the efforts we're putting in? What kind of organizational culture do we really want to have? Some personal assessment questions that you can ask yourself. What are some things you can do to reduce the sources of stress in your workplace? What are some changes that could help your workforce better manage stress? How can you do your part to address parallel processes that may be occurring? And what could you do to help resolve organizational grief? All be said, anyone who takes the goal of prevention seriously is bound to recognize that it involves social reform. And that's really what we're talking about. One of the most profound impacts of understanding trauma and adversity and its impact on health, mental health, and social health is to recognize that pretty much all of it is preventable. And most of what you learn and will look at within your organizations, you can do something about. You may not be able to go out and instantly change the social and financial inequities that are in the system, which are profound, but you can change how you interact with other people if you want to, and if it's a problem. And what you're going to find in this analysis is that there are problems that exist that are a result of all kinds of bad things that have happened to your program and to your people. And that it's led you to adapt in ways that may not be particularly healthy, but that you can change if you want to. Now, I'll leave you with just, I want to tell you about CTIP. That's the Campaign for Trauma-Informed Policy and Practice. We are a volunteer agents organization at this point. I'm chairing it. And our mission is to educate members of Congress and their staff about all of these issues. And just for your use, on our YouTube channel, there is, I have a step-by-step guide to creating a safety plan and a step-by-step guide to creating a wellness plan, so you can just download. And then that's my website, and that's the Creating Presence website. You'll have a handout for this. And that's it. I'm going to stop the share. Okay. Good.
Perfect. Dr. Bloom, thank you so much. As you and I had discussed, we definitely have some chatter in the Q&A and a couple of questions in particular that we hope you have some time to answer. But thank you so much for such a stimulating and affirming session on so much. We actually have quite a bit to think about as a department, as leaders, as parts of teams, as units all across not only this hospital setting, but all throughout our community. The first question that I have for you is how do you consider violence in the context of this social splitting and polarization that you're describing? Often, when the voices of marginalized communities are elevated, those who aren't part of those groups or identify as part of those groups feel that they're being attacked and enact aspects of fragility. So, we're curious if you could speak to that dynamic.
Yeah, I think it's a sign of enormous many decades of traumatic experience, and not just for the marginalized people who have often, at least in the past, had it the worst, but really for everybody in the culture. And it is in the best interest of people who are abusively using power to keep people who have common cause from actually collaborating with each other. And so I think it's important to look at the violence, no matter where it comes from, when it is promoting social splitting versus when it is about healing social splitting. There are lots and lots of people in this country, people of color and people who are white, who are suffering horribly, often for very similar conditions at this point in time, and yet are being polarized because it's in the best interest of those who abusively use power. So that's the way I think about it. And I think we do then whatever we can to have empathy for everybody that's suffering. And it is hard. If you're a white person, it's hard to grapple with what has happened in the present and historically to marginalized peoples at the hands of people you may have voted for, you always believed were fine. So it's an awakening for the whole country that's happening, a long overdue awakening. And I think we have to try as best we can to understand other points of view and call out really irrational rumors. I mean, there's a lot of crazy stuff out there, and social media promotes it. And I think it's our responsibility to say, wait a minute, nothing is that simple, and nothing is that clear in the divide. Otherwise, we continue to play into the hands of those who would like to keep this country polarized.
Thank you so much, Dr. Bloom. We do have a couple of other questions, although I think given the time, I will take you up on your offer to email them to you. But please know we have lots of kudos and appreciation for you and your talk, the points and the challenges, the invitations that you've shared with all of us, and a request to share a PDF of your slides if you're okay to do that. Again, thank you so much for spending time with us today, and I'm sure the ripple effects of these conversations will be seen for some time to come. Thank you to all of you. Thank you. Thank you for all of you who came today, and please stay tuned for the feedback request for evaluation. If you haven't already seen it in the chat, it will come to you over email as well as a registrant. Thank you so much, and have a fantastic day.
Bye, everybody.
Bye-bye.